My dear colleagues, on behalf of WONCA Europe, for me, as the President-elect of WONCA Europe, it is a great pleasure to moderate and to host today this WETalk, which has the main topic of primary healthcare and continuous transition in Europe. We have two very dedicated speakers, which we are very grateful that despite all busy schedules, all things we do, they give us the option to have them here and to share with us her perspectives. The first speaker of the day will be Dr. Toni Dedeu. Dr. Dedeu is at the WHO European region a senior advisor for integrated primary health care. He is, by profession, a family physician, but also a urologist. He is holding 3 master degrees in health economics, primary and community care, and healthcare management. He has a very high expertise, as he was also the chair of the European Association of Regional and Local Authorities. He was a CEO of the International Foundation for Integrated Care. He is quite well linked and well known in the WONCA family, since he was a former member of the WONCA Council and also an international officer of the Spanish family of Community Medicine Society. And also he was a member of one of the WONCA Europe networks of EQUIP. So he is a real advocate of primary healthcare, integrated care, and digital care. Furthermore, he was also integrational and active part of many European projects. He's active as scientific and senior person in advisory boards in several EU projects. So, Toni Dedeu, it's a pleasure to have you here. We are looking forward for your speech. The floor is yours.
I hope you can hear me. So thank you so much, Thomas, for this kind introduction. And I feel part of the WONCA family. And one of the things I would like to say is, first of all, I don't know if there are people from different regions in the world. So first, good morning, good afternoon, and good evening. This is a pleasure. And I must say, thank you for inviting WHO, and in this case, myself, to this WETalk. So Thomas already introduced me. So I'm the senior advisor on integrated primary healthcare at the WHO European Center for Primary Healthcare. And I'm here, in fact, on behalf of the WHO European region. So the Center of Excellence on Primary Healthcare is based in Almaty. And this is very interesting because Almaty, as you know, is the current name, and the former name of the city was Alma-Ata. And I think this is well known to all of you. So just to give you a glimpse, the WHO European region has 53 member states with a population of over 1 billion citizens. And this is, I think, is a very similar country composition as it is with the WONCA Europe. So we are aligned, and we are going to talk about similar context. So one of the things I'd like to say is I would like to invite you to go to 1978 to Alma-Ata. The Alma-Ata Declaration was a historic call for urgent action. On one side, to protect and promote the health of all people. And in this slide, you can see a lot of examples of key documents and significant dates where the vision has been implemented. This is something that I'm very happy to say. Specific actions have been put in place and evidence has been generated. And as you can see on the right side of this slide, I would like to announce you the latest publication of the WHO and the European Observatory. And this is implementing the primary healthcare approach, a primer. And the primer consists on evidence It's not just at the European region, but it's a global evidence on primary healthcare divided in several chapters. So I invite you to download the document, because I think it's for you to be updated on the latest evidence on primary healthcare. However, I would like to say that the potential of primary healthcare is still maturing and adapting to the new challenges. On the right side of the slide, the Astana Declaration reinformed the importance of the Almaty Declaration. And I would like to highlight that the Astana Declaration positioned primary healthcare-led health systems as the cornerstone of universal health coverage and a necessity for responding to health emergencies and promoting health and well-being. Today, we see the countries that most fully implemented those principles are achieving the best health outcomes and greater health equity for the population. And this matters to WHO, and this matters to all the professionals working in primary healthcare and the citizens. However, we know that the pandemic has been an eye-opener and a litmus test of health policy decisions. And now, what I would like to do, we all know that about the what, so as I presented in the other slide, and I'm going to and I'm not going to go over on that, but let's move on the how of successful primary healthcare transformation and its success factors. I would like to recall the global commitment to primary healthcare in the Astana Declaration, which stated that the primary healthcare needs to be transformed into visible actions to bring about demonstrable change. So I say three words here: transformation, actions, and change. So in 2018, the WHO, together with UNICEF, we published a document, A Vision for Primary Healthcare in the 21st Century towards Universal Health Coverage and the Sustainable Development Goals. And the document proposed a set of levers that would help countries make progress across three components of primary healthcare. On one side, multi-sectoral policy and action. Secondly, empowered people and communities. And thirdly, primary healthcare and essential public health functions as the core of integrated health services. Aligned with these three components, the WHO has identified a set of key implementation actions to transform primary healthcare. And those are focused on one side, on governance, on workforce, on organizational innovation, and last but not least, renewal of physical and digital infrastructure. And this is something that is it matters to many of the countries of the WHO European region and globally as well. And I would like to say that in 2020, the WHO published the operational framework for primary healthcare that I would recommend you to visit it. Let me see. Yes, and I would like to emphasize again something that about the Astana Declaration that positioned primary healthcare-led health systems as the cornerstone of universal health coverage. And I think this is the strongest statement that one can say, because it's bringing together universal health coverage with primary healthcare. It positions primary healthcare not at the gatekeeper of a system. It puts primary healthcare at the starting point of the whole health process that a person can follow. But there is still some gaps. And as you can see in this slide, there are still gaps in coverage of medical products. And in many cases, those are not monitored. There are gaps in coverage of medicines in middle-income countries. And there are gaps in coverage of dental care in all countries, with no exceptions. And this covering higher cost care is not enough to secure financial protection. And there is financial hardship that is driven by out-of-pocket payments to people, and especially these effects to the people with poor conditions. And the poorest households, they struggle mainly for paying for medicines and medical products. And my reflection is there is no effective primary healthcare if what is prescribed or recommended cannot be accessed. So this is a very strong statement. This is mine. Don't attribute that to WHO, but I think it really matters. And there are still concerns to retaining gains achieved in primary healthcare. So we've done well, and this is something that I was discussing before with some colleagues. We've done pretty well. But as you can see, in preventable mortality, we are improving, and there is still a large variability among countries in access and non-met needs. And as said before, there is still large catastrophic healthcare payments. So this is evidence produced by both the WHO Barcelona office on health financing and by data coming from the OECD. In addition, and this is something that I would like to highlight, but it's not the main topic of this presentation, 1 out of 3 countries in the WHO European region, more than 40% of the doctors are over 55 years old. We all know that. And what are the implications? It's future shortages, and there is a call for starting planning now. So we cannot delay the planning on that. And one of the things I wanted to do now is those facts should make all think, and we shouldn't delay any action in transforming primary healthcare. We are all actors in here. So from the policymakers, decision makers, practitioners, and the citizens as well. But there is also good news, because there are many good examples of initiatives and strategies transforming primary healthcare. And for today's talk, I propose a pragmatic framework to rethink primary healthcare models. On one side, what are the health and well-being needs in the community? What services are needed to respond to this need effectively? What, sorry, I didn't change the slide. So what are the core competences available, and where are the gaps to deliver services? And how are services organized, coordinated, and delivered? And what resources are needed to make this happen? Let's talk about money, physical, human, digital solutions. And finally, we must create evidence. And I'm going to insist on that. How do we know we are making an impact on needs? So going back to needs, this is what I'm going to follow this scheme. So I would like to share with you, even well-performing primary healthcare systems are challenged to respond to continually growing expectations and needs. And another thing that it's interesting is that there are gradually increasing pressures and societal changes. And I'm going to be a little bit disruptive here. In addition to what we all know, increasing rates of multimorbidity and disability, cyclical financial and economic crisis, COVID pandemic, now there is a shift in cultural values and expectations. From the workforce side, there is work-life balance. This matters to the new generations, professional development, research, team working. And from the society in general, there are new values: immediacy, consumerism, technological fascination, and fluidity of bonding and relationship. And my question is, how is this going to impact and affect the way we provide services? Let us start with a fact that really matters, and there is evidence that we need to address to the most vulnerable. So one key priority in primary healthcare is to proactively reach out and engage those at high risk and at the most vulnerable conditions. In primary healthcare, social complexity is equally important as clinical complexity. Tailored services, needs-based approaches work better. Moving from the waiting room to outreach the community and anticipated care is something that we have to do at primary healthcare. Use of data to identify those most vulnerable and complex needs is not a difficult task, but data alone does not work. We must act, and we must go from digital to human. And for that, we've got tools to anticipate needs, to know the current needs, and to work proactively. You can identify populations according to their health and social needs. On one side, socioeconomic, cultural backgrounds information, in addition to the health data. And there are some basic requirements. First, individuals should be empanelment or registered to a primary healthcare center, a facility, to a GP, to a nurse. And secondly, there are always ways and tools to collect and process the information. And as I mentioned before, this is not rocket science nowadays. We found more than 10 WHO European countries using a concept that's called population health management and their tools. There are good examples in Lithuania, in the UK, in Spain, in Italy, in Uzbekistan, in Kazakhstan, in Germany, and among others. So this is important, and I'm not going to give examples of individual countries because this is something that's happening in many of them. And what about what services are needed to respond to this effectively? So I'm going to use, before I go deeper, this is time to clarify the basics. So on one side, there is no universally accepted list of what primary healthcare services are or are not. So we can use different lenses, the ones that you can see on this slide. So on one side, continuum of services from promotion to palliation, and the 4 Cs. This could be the first contact, continuity, longitudinality, comprehensiveness, and coordination. And data from the preliminary survey from the OECD patient-reported indicator service Paris that the next speaker is going to talk showed that longitudinality of care increases confidence and perceptions of quality. This is very relevant. And now I'm going to talk about another service provision that primary healthcare can or could or should provide. So those are services with a very huge variability. And this is in long-term care services in the European countries. You can see here the various countries from Israel to the Czech Republic, the different unmet needs of both from end to end. On another side, I would like to talk about mental health. Too many young people are not receiving the mental health support they need. 50% of young people between 18 and 29 in the European Union reported unmet needs for mental health care services in spring 2021 and as well in spring 2022. More than double the share for adults. And this is a very, very, very shocking fact. So primary healthcare must play a role here. And what strategies to scale up health services in primary healthcare have we seen in different countries? On one side, the expansion of services with multidisciplinary teams and family members. Sorry for that. There's something in my computer that it's not working well, can't see. And family members as frontline workers. The second one is engaging with community organizations. Thirdly, coordinated support of a specialist to primary healthcare. Not the primary healthcare delivers to referrals to a specialist, is the other way around. So the primary healthcare practitioners, they play a key role on that. And then upskilling. You need upskilling, you need training, you need task definitions, roles, who can do what in this aspect. And I'm going to go now to another service provision. This is at rural health care. And the example, a very good example, is in South Lapland in Sweden. The WHO has launched what we call it a demonstration platform, and we invite countries to visit the northern Sweden in the region of South Västerbotten in South Lapland, just to experiment and see firsthand, and including capacity building activities while they are visiting, because the interesting thing is they've really rethought the model of services they provide in rural areas. For example, they've got some facilities. They are called cottage hospitals because, in fact, what they are general practitioner-led community health centers, and they include the small numbers of inpatient beds, geriatric and palliative and social care included there, requires greater scope of work and competences of GPs and nurses, and for that, even the doctors in that center and in the region Westerbotten in general, they have an additional 1 year training of rural doctors after the training as a family medicine doctor. Additional year of training in University of Umeå, and then the nurses do the same, some capacity building and courses in the same University of Umeå. So as you can see, what happens there is that the aim is to bring services closer to the people with a multimodal approach, I would like to say. On one side, they keep providing, that's important. Let's not to forget that. Face-to-face at the facility, face-to-face encounters, and then face-to-face with mobile teams is the team who goes closer to the people. And finally, they use remote delivery with telemedicine and other digital solutions. This is a very interesting example of how we can tackle some of the big problems many countries have. But I would like to add another thing, that strengthening primary healthcare via digital solutions shouldn't be a vertical program. This should be an integrated part of the system design embedded in the primary healthcare model. And another thing, it should be co-designed with the end users. And this case is the people, the citizens, patients, and the healthcare professionals. But the good news is that I would like to bring some good news as well. And this is, again, some information from the OECD. And we know that asthma and COPD hospital admissions are decreasing. And this is a good reference and indicates that community health care is improving as a comprehensive approach. So this is a good sign that primary health care is doing well because we are reducing that. And what are I'm going to move now to the competences available and where are the gaps in when delivering these services. We know that there is huge variability in the primary healthcare composition. As you can see on the slide, from England to Estonia, to the Netherlands, I think there is Spain, Slovenia. So you can see the different compositions of the teams. So I would like to say that since tailoring to the context is so important, there is no copy and paste from one country to another one. There is not a blueprint for team composition, but there are some key components, some elements. I'd like to say that a strong family medicine and advanced nursing roles are the backbone for high-performing multidisciplinary primary healthcare teams. Then non-clinical roles and community health workers, for example, social workers, are essential to delivering a wider set of services. And there is a growing attention to addressing the increase in mental health care needs, as I said before. And a very important one, teamwork is not the same as collocation. I'm going to repeat that. Teamwork is not the same as collocation, and it should be constantly embedded and promoted. This requires a specific time, a space, a clear definition of roles and responsibilities, and a supporting legal framework, among others. And here we've got another good example of innovation in management competences and skills in the primary healthcare workforce that can be found, in this case, in Spain. Multidisciplinary care teams adapted to COVID-19 in Spain, expanding professional roles, shifting tasks, and adding new members to the team. So, for example, primary care nurses gained autonomy and team up with social workers. Health administrative staff moved from passive appointment dispatchers to patients' demand managers, channeling needs to the most adequate team member and releasing clinical staff from administrative work. So this is something that in many countries, when we do some assessment from WHO, this is what we find, that the family doctors, they are still doing some administrative work that could be done by any other member of the team. I would like to give an example about expanded primary care teams in Kazakhstan. This is that there are more nurses, psychologists, and social workers in the team working side by side with family doctors. And in this slide, you can see that there is a reduction of specialist visits and hospitalizations in Kazakhstan in that moment. So it's not that we only talk about Western European countries. In Kazakhstan, there is like a revolution of what is happening in primary healthcare. That's why I wanted to share that with you. And another thing is how our service is organized, coordinated, and delivered. We know nowadays that there are some new trends. And maybe some of you heard about the provider networks. So, for example, provider networks are well extended in the UK and in some other countries with different names. There are ecosystems or some health areas that bring together different stakeholders. And what's the importance of that? Because these provider networks can employ a wider range of clinical and non-clinical staff in multidisciplinary teams on one side, can improve access as teams can cover extended hours. They have greater financial stability, and they can support management teams to improve organizational processes and support. Those are some of the examples. And what about resources? I'm going to focus on, I want to say two messages on funding and on primary healthcare governance. On one side, there is need to increase primary healthcare funding, no doubt, everywhere in the world. So this is something that I like, is my other statement. Second, we also need to increase the power of primary healthcare at all governance levels, So improving, one of the things I wanted to relate that is improving population well-being will require economic investment in primary healthcare. So if we turn the sentence on the other way around, primary healthcare has to be better funded to improve well-being of the population. And this has to be done strategically. Here there is an example, and I highlighted Estonia here, because we have strategically, we have to make the investment case for primary healthcare to set priorities, but at the same time to incentivize what matters. I keep with resources, I keep talking about resources, and now obviously I have to talk about workforce. I don't like to talk about resources when I talk about workforce, talking about resources, but the one of the things that is already happening here and is that the share of generalist medical practitioners, family medicine doctors, continues to drop across the majority of the OECD countries. And this is an example of happens with many countries. As you can see, the average of the OECD, a few countries like Lithuania and Greece, they are increasing, but there are exceptions on that. So the key question, are human resources policies aligned with our needs and current models of services? You can see in this slide, the huge variability. So health workforce planning to get numbers and composition right, education and training, including digital skills, financial and non-financial incentive for the workforce population, and health and well-being support for the workforce. This is something that the well-being of the workforce support, sometimes it was forgotten, and I would like to highlight this as a very important issue as well. And at the same time, I'm not going to read this slide, you can do it. The countries should prioritize full range of health workforce policies. So it's not just one policy, it's a set of policies to develop. So, and how do we know we are making some impact? This is the other question I want to say. So, and in this forum, I would like to say that generating evidence is a must. We must do it, all of us. So there are many tools to generate evidence. Some tools can support, for example, one of them is to apply the WHO UNICEF primary healthcare measurement framework and indicators, monitoring health systems through primary health lenses. This is a product, but there are many others, and the OECD has got other tools as well. So I'd like to say that it's important to what are the high impact strategies? You can see them here. So is expand the scope of services, establish and sustain multidisciplinary teams, develop mobile teams and services, expand and deploy digital healthcare solutions, establish and implement comprehensive health workforce strategies, as I said before, invest in infrastructure and equipment, and align health financing strategies with the broader strategies, and bringing together all the other partners and stakeholders in the area. So another thing, what about the knowledge products and assessing primary healthcare transformation? And now I'm about to finish. I'm just going to give a glimpse of 2 or 3 things that we are doing in the WHO at the WHO European level. So we've been developing some country vignettes. We've published 16 country vignettes series on transforming primary healthcare during the pandemic. I invite you to visit that. The link is on the screen, but I'm happy to share my slides as well. So one of the interesting things here is that each country had some transformation innovations in the health system, and most of them are transformations that they persist. They kept in the system. So that I would like to send a positive message that we've learned a lot, but we've gained a lot as well in innovation and transformation as a result of COVID. So and last year, for you to know, we published our WHO Center 5 policy papers, 2 on thematic areas, 1 on population health management and the other one on networks, and 3 country studies of Spain, Georgia, and Kazakhstan. They are fully available on the WHO website. And obviously, what we do is country support, country assessment. And as you can see on the slide, we are working currently in almost 30 countries out of the 53 of the European region. And one thing that I would like to say just to finish my presentation is that in October 2023, in the WHO UNICEF conference to commemorate the 45th anniversary of the Almaty Declaration and the 5th of the Astana Declaration, a youth-led outcome statement resulted in 5 asks. You can read the asks in the slide, and you can see that this was led, and that's important, by youth representative from the WHO Regional Office for Europe, and at the same time from WHO Primary Healthcare Young Leaders Network and UNICEF and youth representative. But even Wonka was consulted to have some inputs in the outcome, the statement. And just to finish, I'd like to finish with a quote from the WHO European Regional Director Hans Kluge. And he said, reframing our health systems with a primary healthcare lens is not just a choice, it's a moral obligation, a prerequisite to the kind of society in which we all aspire to live, a society grounded in trust and empathy, where health and happiness flourish for all. And I'd like to say thank you very much for listening. Thank you.
Toni, thank you so much for that excellent and very interesting talk. It was also mentioned in the chat. People saying it was a great talk, and they feel that our colleagues from other countries may learn. We will now go for a brief round of questions. Some were coming forward. Ferdinando Pepazzoli is asking, what can WHO Europe do to address the problem of the huge workload, so the shortage of primary healthcare personnel? Can it be politically influential towards single European countries? And do you think that the economical concerns are really the biggest per year?
Sorry, could you repeat? I didn't answer.
Whether the economical concerns are really the biggest per year which primary care should have.
Well, I think I wouldn't put that the economic constraints are a problem. Sometimes I can see that there are opportunities to rethink how we are doing. One thing that I said is in the general budget of the for example, the Ministry of Health should be more money allocated to primary health care, and this is because I've already mentioned the impact in the well-being society. And there is evidence that the more you invest in the well-being in primary healthcare, the better outcomes in results on the well-being of the population. This is one thing. So that should be a political priority. So I say political priority, political commitment as well, and most of all the countries that they are on the member states on WHO, they commit and they subscribe this. So increase the budget in primary health care. So this is something that they are committed. So if they don't do it, so it's something that is political will as well. So then we know that we are struggling in we are in moments that economically the world is not in the best position, but that doesn't mean that we cannot be innovative in transforming. And this is the example of what we discovered in those 16 country vignettes that we produced as a result transformation initiative during COVID. We were absolutely surprised how the transformation levels, even with the situations that the COVID pandemic produced, the innovation level that happens in the primary healthcare sector. So this is something that we shouldn't be just so attached to. There is a economic constraint. We should rethink the system, and with the same money, we can do much more. Maybe this is one of the things.
Yeah, thank you, Toni, for that answer. There are 2 questions and remarks in the chat. You also mentioned, Toni, palliative care. And one colleague is wondering about the integration of palliative care and primary care in Europe. Could you give a statement on this and express your opinion on this?
Yes, about palliative care, I didn't want to give some specific concrete examples, but there was one slide with 2 or 3 countries that they excel in palliative care. And then the question is this related to the efforts of primary health care, or is because there is a parallel system on palliative care? One example is for example, the Netherlands. They've got a very strong palliative care approach, but maybe at the primary healthcare level, there should be, I never like to say integration, I like to say coordination. But in this case, palliative care, I think the primary care teams, they play a key role in triangulating doctor, nurse, social worker with the needs, because palliative care is not about health, it's about the conditions, the family, and the needs of the person. So I think here, primary health care plays a key role. So I understand that there are different levels of maturity of primary health care, the scope of practice of primary health care, but one ultimate goal should be, as we say in the definition of even family medicine, from birth to death, So it doesn't matter in the life course, in the condition you are, but at least even if you are in a very early, late stages in your life, you need to talk to the nurse that you've normally seen. You need to talk to the GP that you've always had. And this is something that many of us, and now some of us, we are struggling with our relatives, elderly people, parents, grannies, and whatever. We know that that's important. And when the family doctor goes to the home, when the nurse of the primary healthcare nurse goes to the home, they are so released. The people are very happy. So I think we should reinforce the role of primary healthcare in palliative care. So.
Okay, Toni, thank you also for this. As I mentioned in the introduction, you're really an advocate for primary care and for strengthening it. But there's also the question coming in chat on a practical level. What would you recommend to GPs, to family doctors, which actions to take to bring different stakeholders together in order to go really forward with strengthening and transforming primary healthcare?
One thing that I would like to say is that there is future for primary healthcare. So there is something that is not that is the people who join to family medicine, being nurses, doctors, or the people who join to primary healthcare. I think is in a way it's more than vocational. So we have to go beyond the vocational side, but we need to bring opportunities for professional development, and this is very important, you know. And another thing that we can see that in countries where people work in multidisciplinary teams, there is much satisfaction that the countries that the people work on solo practices, because the share of knowledge between the different professionals helps to keep being motivated. So one of the things it should be is that in the countries where there are no departments of family medicine in the universities, that should be a must. So that we should be introduced. Then in countries where nursing are still non-graduate profession, they should move towards a bachelor degree. And then thinking that the doctors, I would like to say that we should be very innovative in trying to bring flexibility on the roles that family medicine doctors can play. For example, if there is some people would like to work 4 hours, some people would like to work 6 hours plus doing 2 of research. This flexibility of contracts in many countries doesn't exist, and this is the limitation for access. So I'll advocate to promote those areas that can motivate the physicians and the family doctors and nurses to join to the primary healthcare course, because course, I mean, of course, as the field. And another thing that I would say is, and this is something that happens in many countries, is having some rotations in primary healthcare should be a must for all the other specialties, and including that should be a rotation of postgraduate. So when you are a resident in rural areas as well. So because when we talk about desert medical deserts, maybe some of the residents would like to become rural doctors and things like that. But there are many strategies. I could be talking for hours about that, and I've got other colleagues specialized on this topic. So maybe a good way to invite them to have a WETalk as well on this field. So I'll tell to them, because they'll be very glad to discuss that. Over from my side.
Okay. Thank you, Toni, also for these comments. In the chat and also in the Q&A, there's also mentioned the issue of young people with mental health problems. The numbers are frightening, it is sad, and we have clearly seen this. What would you think? How could we improve that situation, especially the situation of long waiting times for diagnosis, support, or treatment, and maybe even unnecessary but preventable deaths?
Yeah, this is, I think I even put a slide on that. So one of the things is that mental health care has to be tackled as well and dealt at primary health care level. So this is one thing. Secondly, this is part of the community. The second thing is that people have to be trained, and some interventions can be done. In some countries, they've included psychologists in the primary health care teams. As I mentioned, Kazakhstan, but there are other countries with psychologists. Northern Sweden, they've got psychologists in the team. And at the same time, the family doctors, they play a role, sometimes in minor diagnosis, and then the consultants can support on them. And we have to be in, there are many even European projects in trying to discover, to highlight how we can be proactive and not reactive to mental conditions of young people. And I think this is we can open a new window on that. And obviously from Wonka. This is something that is been working for years, but we have to convince politicians that this is something that is a priority in this moment.
Yeah, yeah, fully agree. Tony, thank you. Regarding the time, it's a little pity we have a very active discussion. It's very interesting questions. It was the question where the webinar will be accessible. To say it, it will be on YouTube. It will be accessible since it is recorded through the Wonka Europe webpage. We will also try to make the slides available. We have to clarify this with you as the speakers. And we may also consider to catch up with some questions which could now be answered and answer it later on for those who were registered via mail. Regarding the time, I would like to thank you again, Toni Dedeu, for this very inspiring and very interesting talk. But we have to go now to the second presenter of the day, Ms. Candan Kendir. She's a health policy analyst at the OECD. Her main working focus is how to enhance care quality through the systematic collection and application of patient-reported outcomes and experience measures. Currently, she's working on the OECD's International Paris Survey, which assesses PROMs and PREMs in adults living with chronic conditions and who are receiving, of course, primary care. Candan is also a family doctor and currently to have you here today. We are looking for your talk. We will take time to answer questions and to discuss after it. So, Candan, very warm welcome. The floor is yours.
Thank you, Thomas, and thank you so much for having me here. This was a very nice presentation from Tony, and he set the scene actually for many things that I'll tell in my presentation. So some parts will move quickly, probably, but the idea of enhancing people-centered care, transforming health systems, it's very nice. We hear it very well everywhere from different people, policymakers, and other stakeholders. But the question is how? How do we do it? How we should do it? Where to invest? And giving the resources that the policymakers have or other decision makers have, where to invest in primary care to get the best outcome and the experiences. So today I'm going to share with you our work on the OECD's International Paris Survey and the implications from it for primary care. Very quickly about the OECD, it's an intergovernmental organization which has 38 members. Our main area is economic analysis, and we apply it to health and health systems. Tony showed many examples of our work. We have international data collections and international benchmarking. Our main objective is to advise policymakers for better policies, and in the case of health, for better policies for better health. And of course, we have this forum for policymakers and stakeholders. So we are measuring health systems performance in delivering primary care, but where do policymakers look at currently? And previous presentation showed many examples of it: number of general practitioners, nurses, prescriptions in primary care, mortalities, morbidities, and also avoidable admissions to hospital. I'm not saying that these are not useful. These traditional measures are necessary, but there is a move. There is a move towards new generation of health measures, because from fragmented health systems, now we are moving towards integrated health services. We have more and more people aging and living with chronic conditions, visiting different healthcare settings, seeing several healthcare professionals for various problems. We need them. From production, the question is now moving towards to value. What do we want to get out of the services that we are providing in the healthcare in primary care? From processes and outputs, we are moving towards outcomes and experiences. And of course, from disease and supply-oriented health systems, now the topic, the theme is moving towards people-centered health systems. But when looking at this big picture, where policymakers make decisions, Where do the core attributes and values of family medicine stand? I'm pretty sure that many of you are familiar with this Wonka tree. You know it much better than me, but I highlighted some key aspects here about person-centered care, holistic modeling, or primary care management, comprehensive approach. So we need to say something about this by looking at data from primary care. So this is why we have a new survey in primary care through patient-reported measures, because policymakers need evidence and the data need to come from primary care and also taking into account the core values of family medicine and primary care functions, and of course, voicing what really matters to patients and their primary care professionals. So that's the idea. PARIS stands for Patient-Reported Indicators Surveys. It's an international survey of patient-reported outcomes and experiences of people living with chronic conditions who are managed in primary care. Well, good news, we have been talking about political commitment, and this was a political commitment from OECD countries where health systems wanted to transform their health systems to be more people-centered, though by measuring the patient-reported outcomes and experiences. So it's an OECD initiative which benchmarks outcomes and experiences of healthcare that matter to people. And the flagship of this Paris initiative is what we call Paris Survey, focusing on people living with chronic conditions who are managed in primary care. Maybe just a quick parenthesis here to talk about what we mean when we say patient-reported outcomes and experiences. These are reports of status of patients about their physical, mental, or social health, also quality of life, also interactions that patients have with the healthcare system, with their nurses, doctors, and other stuff about care coordination, about trust, about shared decision-making. This should directly be reported by the patient without any interpretation of a clinician or someone else. And more, we see and we hear that patient-reported measures are used across various levels of healthcare system. So it might be used in a micro level for practice improvement. We know that it's used for shared decision-making or communication between clinician and patient. In meso level, it can be used for quality improvement in organizations. And on macro level, it can be used for systematic performance measurement and improvement of health systems performance. So the Paris survey is looking at this last angle about macro level improving health systems through patient-reported measurements. The purpose is clear. So for the policymakers, the idea is to make health systems more people-centered. When it comes to patients, making their voice heard, and when it comes to healthcare professionals, improving quality of care that primary care professionals provide. And the idea is that Toni talked very well about the co-development process in primary care, and this is also the case for the Paris survey as well. We have several key stakeholders here: policymakers, patients, primary care professionals, and also academic researchers, because this is the idea of building a bridge between the technical features. You need to make sure that the data is international comparable when we say something about it, but also practical applications. So it should be relevant for patients and also primary care professionals. For this purpose, we have been working with a group of stakeholders since 2017. So they were even involved in the discussions when we were discussing which chronic conditions to include, how to design the survey, which questions to ask in the questionnaires. I'm happy to say that today there are 20 pioneer countries, more than half Wonka Europe members, who collect data in 2023 and finalize their data collection now. So currently we are processing this data, cleaning and preparing it to be released a flagship publication later this year, early next year. And when we talk about the Paris data, we are talking about 100,000 patients data and around 1,500 primary care practices. Why these different groups of data? Because we are not only asking patients who are 45 years old and over, living in the community, who had the contact with their primary care professionals, but we are also asking their healthcare professionals, primary care professionals, who are serving to general population and who provide general care, including chronic care management. Because the idea is to look at the patient reported outcomes and experiences, but in the context of primary care practices by looking at the characteristics. I'll share more examples of it in a minute. And of course, we are not stopping there. We are also asking policymakers, what we call nation project managers, who are experienced in conducting large-scale surveys, have expertise on chronic conditions and primary care systems at national level. And the idea here is to look at the health system characteristics and how they impact on it. So very basically, this is a simplified version of the Paris conceptual framework. What you see here on the right side is, so this is what we assess mainly, patient-reported experiences and outcomes. And we are asking them about individual and social demographic factors, income, education, but also migrant status, whether they had any financial difficulties to buy food or their housing conditions. We're also asking them about health and healthcare capabilities, health literacy, self-efficacy, self-management, and so on, and also health behaviors and lifestyle. On the provider level, we are asking about primary care characteristics, whether it is located in an urban or rural area, whether it's a multi-professional primary care practice, or it has digital tools available in the practice, and then asking about the health system design and policy context. So the idea is that when we talk about this ideal primary care, what should be in the primary care and how it should be organized, the idea is to say something about it by looking at patient-reported outcomes and see whether it makes any difference in terms of the patient's experiences. So here I present you 10 key indicators, which make the solid backbone of our flagship report that is coming later this year. So we have 5 outcomes there: general health, physical, mental, social health, functioning, and quality of life. And when it comes to experiences, it's about quality of care. We talked about trust in the previous presentation, which is an important part, confidence in self-management, care coordination, and care tailored to the individual needs. Examples of questions, but here I'm sharing the links with you so you can have a look at the whole question of the primary care practice questionnaire or the patient questionnaire. So we are asking whether their family, friends, carers are involved in shared decision making and how people rate their mental health. Also asking primary care professionals about how much time is scheduled from the health systems level for their practice for different actions that they are doing in their daily work. So the idea is to answer some key policy questions, and a few examples again here, whether chronic conditions, people with chronic conditions report different outcomes and experiences based on the location of the primary care practices, or by different socioeconomic characteristics, or in certain primary care practice types, they have better experiences or not, or when they have digital health in primary care services, does it have an impact on the experiences of people, and which groups are more vulnerable? So we need to target them in our policy actions. And these are only selected examples. As I said, there will be much more than this, focusing on inequalities, trust, multiple chronic conditions, and so on. Again, Toni also showed some examples of this, but we had some preliminary results. And again, I say these are preliminary results. These were based on a partial set of data set from the Paris and not completely clean standardized, but we showed that in countries with better rated primary care, people with multiple chronic conditions rate their health as better. So a reason to invest in primary care. Another reason to invest in primary care, in countries with better rated primary care, people with multiple chronic conditions are more likely to trust the healthcare system. And the last example is about the same one that was already used. Longer relationships show higher levels of trust and also better quality of primary care. These were shared with OECD health ministers in their meeting in January 2024 in Paris. And as I said, there will be the main results published later this year, showing the whole spectrum of the policy questions that we are addressing in this survey. And family doctors have been involved throughout the Paris survey in various roles. You see here, by sharing their individual perspectives, but also methodological support, advice, country-specific implementations, and the international project management team. But this is only the beginning. So this is one of measurement, but the idea is to go beyond it, doing regular assessments, looking at national or regional variations, maybe making it part of continuous medical action, education, professional developments. Some countries are working with their national family doctor organizations to do that, and also looking at national accreditation and certification programs in primary care. So just to finish my presentation, I'm conscious of time. I would like you to remember that what Paris is not. It's not a satisfaction survey. It's not a public benchmarking exercise where we are going to show good primary care practices and bad primary care practices. It's not a tool to pay primary care professionals based on their performance. This is not the objective, the purpose that why we developed this survey. And it's not just to put another burden on primary care professionals. It's a unique instrument to collect data from primary care based on the core functions of primary care for policymaking in primary care. So I'll leave you with this three key messages. The idea is to fill a critical gap in our knowledge when we assess the quality of primary care. But this is just the beginning. There is a transformation. And if we really want to make health systems more people-centered, we need to follow this new generation of health indicators. And it's never alone, not only political commitment, not only patients, not only primary care professionals, but all together. So we need the commitment of all stakeholders to make it happen. I stop here, and I know that we are short of time, but happy to have any quick questions, but you can also follow up with me. You have my email here.
Candan, thank you very so much. It was very interesting talk, and it's very important what you mentioned about the knowledge gaps regarding primary care, family medicine. You mentioned it regarding proms and prems. Of course, a very important matter. It's a similar matter if you think on clinical data, on clinical trials, and it's also a matter if you think and if you're indicating on implementation and implementation changes in daily primary health care. I have not seen now a question through the Q&A session yet coming, but very likely the co-moderators, Sarah or Maria, have also some aspects in mind and want start to ask, or the others may bring forward questions through the chat also or through the Q&A session.
Yes, Candan, we have shared the links of the Paris study from the OECD and also the article that you share. So we put it in the chat box so people can share it. And my question, because you have been working in this study for a few months, should be, what would you think could we improve in primary care to provide a better care for our patients? Which should be the key aspects that we could strengthen to improve care of patients? If you can give us one or two ideas so we can keep it on mind, and maybe we can develop it another day with a little bit more time. We are very grateful because we know you have to leave in 3 minutes. So thank you so much for just making the time to connect and giving us such a wonderful presentation.
Thank you, Sarah. Very quickly to answer your question. What an individual family doctor can do about it: participate in the survey. Participating primary care practices make their voice heard, make their patients' voice heard, but also they receive a feedback report, which is private only for them, about care that they provide to their patients, so that you can compare it to the national average in your country, whether you have self-care management plans, and compare to your national average how you are doing. But as I said, this is mainly developed as a policy tool, and only the final results will show us where to really invest in primary care, because we have been talking about this. And if we do everything that we have been discussing about education, training, resources, outcomes, processes, I'm sorry, but we don't have money for that. Policymakers don't have money for that. So we have limited resources. We need to know where to invest in. And hopefully this will be also a contribution existing indicators about where to invest in primary care. And as I said in my presentation, the most important part is it will be based on the core functions of primary care. It will be about person-centered care, which we all really care about in our daily work as family doctors.
Yeah, thank you, Candan. There's a question from Ireland in the chat regarding the Paris survey. Can you participate as an individual GP if your country is not involved?
Yeah, so
how can others contribute? Sorry.
Yeah, this question comes very often, actually. I should have mentioned it in my presentation. OECD surveys are usually arranged by the governments, by the national ministers of health, or their subnational institutions or affiliated institutions. So if the country is not participating in the Paris survey, individual GPs do not have the opportunity to contribute, to participate in the survey, unfortunately, at this stage. But as I said, this is the first cycle, this is the first measurement, and we'll see what it brings. And who knows for the future cycles, so maybe there will be other opportunities.
Yeah, okay. Good, so thank you, Candan. Another question is coming. Are questions about end-of-life care included, or will it be included into the survey?
This is not necessarily included in the first cycle. Not only because that it's not because that it's not part of core functions of primary care, but it's a matter of prioritizing some main things over others. And it's also because that we have a lot of work streams on end-of-life care at the OECD who are already addressing several questions about it. So this didn't come as a priority based on our stakeholder consultations. But in the future cycles, what we are thinking is having modular type surveys. So there will be a core part, and then there will be an additional part that we will change every now and then. So it will definitely come in the future cycles. I'm pretty sure of it.
Okay, thank you. And Maria Pilar, you have another question.
Yeah, thank you, Candan, for your excellent presentation and very time adjusted. What are the main messages from the perception of patients with chronic conditions about the experience in primary health care?
Well, as I said, now we are working on data with our international consortium. And I cannot make any final conclusions based on the preliminary results. But I can say that what we are really looking at here, as our population is people living with chronic conditions, care coordination is an important part of primary care and functions for this group of patients. So I'm pretty sure that there will be a lot of things that we will say about care coordination, but also people-centeredness, which is also the main theme of this care coordination as well.
Thank you.
Okay, so thank you, Candan, also for the discussion. I would like to thank all the people who were present today, who were very active in the chat, coming up with questions. It was a very nice experience today to have this WETalk with you all together. My special thank goes to Toni Dedeu and Candan Kendir for the presentation, but it also goes to Sarah Iris Blanco and Maria Pilar Aster-Pena for the co-moderation, for activating this WETalk session, and also for the great activity of the working group of Wonka Europe regarding policy advocacy, a very active group, very important for Wonka Europe, and very important for sure for the future to foster transitions and strengthening of primary health care. Wonka Europe is active for all of you and for all of its members. You will see on the website also of our networks where many conferences are going on. There was also in the chat some information about EURIPA meeting at Lincoln. EGPRM will meet. Other networks will meet in the coming months, so try to attend these meetings, use the opportunities, use also the opportunities to review this WETalk and maybe earlier WETalk sessions on the Wonka Europe network, social media, and YouTube channel. It was a real pleasure to be with all of you, and I'm looking forward for the next WETalk. Thank you very much for attending. Sorry that we exceeded the time, but it was without a doubt worth it. It was a great pleasure to be with you all. Thank you and goodbye. Bye-bye.